worries at all. Hi, my name is Pancras, and I am the country lead of YourFitPath in Kenya. And today we have an opportunity to be able to talk to an audience, which is basically the Kenyan market, the Kenyan audience as a country. These are people who are either directly affected by cancer in different ways, directly or not directly. So this means we have an audience that is made up of patients. We do recognize we have an audience that is made up of people within the healthcare sector, nurses, maybe lab techs, and those kind of people within the nutrition as well. So somehow they've been able to interact with people who are affected, and probably at some point they would have wanted, or they're considering traveling abroad for medical tourism. So here I am today to introduce what Your Fifth Path is all about, what we do, and why we have a presence in Kenya. So first of all, welcome to Your Fifth Path. Our platform is designed to transform medical tourism experience within Kenya, considering we do understand that there's some people who want to get quality medical care, but they cannot be able to get it either because of affordability, and then also they're looking for quality at the same time. And within this country, that does not go in tandem. Sometimes it becomes very, very difficult. So as Your Fitpath, we come in strongly and try and provide you with that particular kind of support. So who exactly are we? So we're dedicated to providing medical tourism. So think about it this way: you want to travel abroad, you do not know which hospital you want to go to. You have a specific case, for example, oncology, cancer-related kind of issues. You do not know where to start. That is where we come in within this landscape. We offer a new way to understand and manage your health with trustworthy information and support. So our team comes through, engages you, creates a value proposition for you, and gets your quotation that by the time you're leaving, go to India, you already know what it takes, what kind of services you're going to get, which doctor is going to treat you, and the anticipated outcome. What else do? We provide access to India's largest hospital. In this case, we are partnering with Max Circuit. I would say it's my best hospital in terms of reference and in terms of like the quality and patient experience that they do deliver. And in the long run, in terms of success rates, this is where I would highly recommend. And our team definitely also does that. We do have a commitment to our patients and our customers, and also the partners that we are working with, to strive and make healthcare very transparent and accessible to everyone. This is not the case currently in Kenya, and we're trying to reach out to people so that they can be able to know much more about that. What else do we do? So it's connecting affordable care globally, meaning if, for example, in Kenya, one of the elite hospitals are charging you something like, for example, 5 million Kenya shillings. When you look India, that amount can actually go down to about less than 40 to 50%, which is very reasonable for a Kenyan who's struggling to get better healthcare. So that's where we say now we're connecting the local patient to the global arena where they can get much, much better quality with much, much better technology and better experience in terms of success rates. What else do? We make healthcare transparent and accessible for all. So we do not discriminate in terms of like who should be able to access this based on, say, the technology. Now, give it an example in Kenya. When you want to access specific kind of medical care, probably you need to afford a certain amount of money to be able to access this at either Current Hospital or Nairobi Hospital. With us partnering with Max Circuit, this means that any ordinary Kenyan who's able to raise a certain amount of money based on the quotation that has been provided, let me mention affordable quotation, can be able to access this these services directly without having to worry who they are, or where the hospital is. They're all treated the same, and the access is fully available for all of them. What else do we offer? Definitely, we arrange for free consultation for our patients. Assuming down here in Kenya, you've already spoken to a couple of doctors and you're not satisfied and you're looking for probably a different kind of person to be able to, a different kind of professional to be able to give you consultation differently, then this is where we provide a platform for you. We arrange a meeting with the doctor virtually. They're able to talk to you, assess your documentations, and then at the end of the day, they're able to use that information to give you a different kind of diagnosis or probably a treatment plan. We help you in terms of hospital selection. Not only do we get you a hospital, but we also help you get a profile of the doctor who's going to give you treatment. And apart from that, the other thing that we do is all through the process, we help you get a true world class, I would say best in class patient experience in the world and within the hospitals that from that. So during the whole process, before you start your travel, there's the part where you're worried about immigration. You're also worried about how do I get my passport? The team comes in strongly from India and the Indian hospital, in this case, Max Circuit, which is the hospital that we are partnering with, is able to provide the support in terms of documentations, a letter to the immigration department, so that now we can be able to easily process your passport. And then we're talking about visas, which is the travel arrangements. What else do we do? Normally, when you apply for a visa, that should take, it normally takes between a week and a couple of weeks. And sometimes you're even forced to reach out yourself physically to those, say, for example, the embassies. Taking an example of a patient who cannot be able to move, say they have a medical condition that doesn't allow them to easily move, then that's where we come in strongly as YourFitPath. Me, together with my team, what we do is we work on helping you get that particular visa using support of the hospital, for example, Mark Circuit in this case, and then you're able to get your visa within time record of 24 hours. Done this before, actually does work. So that is where medical tourism comes in. Now, there are some people who ask the question, what if I get to India? How will I survive there? Where will I get a place to stay after probably the doctors already examined me? How expensive is it? Now, what medical tourism does, now YourFitPath, is we give you an opportunity to be able to choose from an array of a few accommodation, either a hotel, or we get you a home where you can stay, depending on how much the doctor needs you to stay in India. We provide you with that kind of support within a proximity, a radius that is much near to the hospital, so that it's not difficult for you to access the hospital for observation before you come back to the country. So it's the pre and post admission as well support. Now, we engage you all through the process. We are not only here for any other reason that would say for your pitch path or for business reason. No, I think your well-being is more interesting to us. So we are walking with you all through the journey. From the beginning, we hold your hand. After the treatment, we still hold your hand all the way back. If you're feeling you still need to speak to the doctor and give some sort of feedback, specialist and give feedback, we help you do that. We arrange that kind of support, and you and hopefully you're happy at the end of the day with all that kind of experience. So there's the post-treatment care, which is also arranged by our team together with the hospital. So by the time you're coming back, you do know where you're going to go for, if it's some additional chemotherapy, if it's anything that is additional that needs to, if you want to continue your treatment in Kenya, we're able to identify hospitals and specialists that we work with to be able, so that now you can be able to finish your treatment within the country. So our process is very, very simple. So in case you're a person who is affected and you'd like to seek treatment, the one thing that we do, for example, is we just ask you to share the documentations of the doctor's report. It is as simple as that. So what are you going through exactly? What were you diagnosed with? We take these documentations and share with the doctor in India. And then from there, they're able to create a new diagnosis, And then from there, they're able to come up with a treatment plan and support you. We also connect you with doctors. We don't assume that when you're in Kenya, you already know who you're going to talk to, who's going to give you the best treatment. No, we give you a profile of the doctors that are going to help you through your treatment plan. We share with you their profile, and we're even able to tell you in terms of numbers what is their success rate in a particular kind of specialty. And we help you select the hospital. We plan the journey with you. We tell you, for example, we have this number of flights that happen during the week. We have a direct flight that happens on this day. And then we also have a flight that is not direct. However, we also advise you on the best airline to use so that you're not able to get any trouble. We have ambulances. If it's someone who needs an ambulance by the time they land hit there, our team in India comes in strongly to be able to receive you so that you don't feel like you're in a foreign land and you're not able to get the support you need that you would have otherwise gotten while in Kenya. We talked about visa assistance. That I think is very, very clear. We support you all through the process. The only thing you're able to do is make the payment, arrival and admission. By the time you're arriving, we don't book you into a hotel. No, we take you straight to the hospital so that you can quickly be able to get the treatment that you're looking for. Support is always ongoing until the day that we can easily say you're now at a path to healing and you're comfortable and you're able to do a few things on your own. That's where now we're able to now let you go and probably just enjoy time with your family. Why YourFitPath? So ask yourself, leaving Kenya going to KNH, Kenyatta National Hospital, it costs you probably $1 max, depending on where you are within Nairobi. So sometimes you're worried, why do I go to India, and how can that be simplified so that I don't feel the weight? That's where we come in as YourFitPath. We tell you, hey, we are going to provide you with a kind of support in terms of probably helping you through with the flights. Those details we can be able to share deeply or in detail. We're also able to help you get there without having to feel the pressure, because where we are, we know you already have a lot of weight on you in terms of either finances. You're really struggling to be able to come up with the amount you need to pay for the bill. So the responsibility of YourFitPath is to make sure that we lessen that burden on you, and you accessing medical care in India doesn't have to be expensive. You don't have to pay a lot of money. So we also support somehow in terms of like your travel and those kind of things. Those are the details we do share. To some patients, we actually do provide free medical, free air travel. We provide free accommodation and those kind of things. I would suggest for anyone who's feeling that they want more information about this, I am so happy to engage you after the call and deep in detail. What are the benefits for the doctors? So this is not only designed for the patients. As a medical tourism firm, one of the things that we do is we have partners. We have doctors, we have nurses, we have people within the healthcare doing nutrition. All of them are working with people who are affected. So what more can we be able to do? There are incentive plans for doctors, simply for referral. There are incentive plans for people who know someone who is affected. Refer them to us so that now we can offer them that particular kind of help. What other incentive is there? Now, look at it this way. From the patient perspective, once you refer them, definitely we are going to like say thank you or do some sort of facilitation. But then again, from the patient side, there's also the part where they're able to enjoy, say for example, free air travel. So this is not information you need to keep to yourself. You need to share it with the patients. You need to share it with the nurses. You need to share it with the doctors. Anyone who's engaging with these particular people at any these affected people at any point in their lives on a day-to-day. I think that's it. I think I will now take this back to Fiona so that now she can help us moderate further and probably invite our doctor for today.
Thank you very much, Pancras, for that
Yep.
brief on YourFitPath.
Okay.
I'd encourage us, if you have any questions for the webinar, either to Pancras or to our speaker, Dr. Shefali, I ask you to post them in the chat. or raise your hand at the end of the webinar. We'll have Q&A session, and you can be able to bring your questions on board. So at this moment in time, I want to introduce to us our speaker for the day. Her name is Dr. Shefali Sadnana. She's a principal consultant in medical oncology with Max Super Specialty Hospital in Saket. She has a Bachelor of Medicine from India, as well as a medical oncology degree from Apollo New Delhi. She has experience in being a consultant medical oncologist in Max Saket as well as Apollo hospitals. She has won some awards, second prize in poster presentation in hematology in 2014, as well as published papers on kidney cancer. Her areas of expertise are breast oncology, gastrointestinal and hepatobiliary oncology, gyna and genitourinary oncology, as well as thoracic oncology. So help me welcome Dr. Shefali. Doc, you're here?
Very good evening to all of you. I hope you can hear me well.
Yeah, we can hear you.
Yes, we can hear you.
And thank you, Dr. Fiona, for a kind introduction. And I'm overwhelmed to see huge participation here in the webinar. And I hope that I'm able to contribute to a great extent in that sharing information, and would be happy to take the questions at the end of the webinar. And I think we should make it more participating and interactive. Just give me a second, I'll mute the phone.
Maybe as we wait on her, I can share a few facts about breast cancer in Kenya. Breast cancer is a third leading cause of death after infectious disease and cardiovascular disease, and it gives 7% overall mortality in Kenya. And unfortunately, 7 out of 10 cases of breast cancer that are diagnosed, 7 out of those are actually diagnosed at advanced stages, which is stage 3 or stage 4. And majority of the age group that is most affected is between 35 to 50 years. So we look forward to hear Dr. Shefali tell us how we can detect these cancers early, what are the risk factors, so that we can have it caught early and treated early in advance. Oh, thank you, Doc. I can see you're back.
Yeah, sure. And can you please share my slides so that I can proceed?
Yes. Pankras, can you share her slides kindly?
You can be able to see
Yes,
some
yes,
projects.
yes. Yes, please. I'm able to see. Can you make it full screen? Yes. So, a very good evening in India, actually. So, to all of you, and happy to share and discuss some of the thoughts about the most here. And I mean, sorry for the network glitches which sometimes happen. I'll be taking the questions maybe at the end of the session, or if there are some questions between, also you can please put them in the chat box. We'll be talking about breast cancer, basically, which is the most common cancer globally. And I'll be talking in the subsequent slides about, say, what are the risk factors, how can we detect it early, and what are the methods of self-breast examination, what are the stages of breast cancer, how does it affect the survival, and what are the treatment modalities available. Next slide, please. Next slide, please. Yeah. So, I mean, when we talk about the breast cancer, there is a big question that can it be detected early, and why it should be detected early? Actually, some cancers can be detected before any symptoms appear by carrying out certain routine tests. And why this is important to detect these cancers early? Because if detected at an early stage, majority and these kind of cancers are curable actually. So that is why the importance of routine tests and early detection is there. Next slide, please. Yeah. So for this detection, we need to be aware of actually certain facts. that early diagnosis is the key to surviving breast cancer, and nearly 97% of the women who are diagnosed with breast cancer at an early stage, that is stage 1 or 2, survive for more than 5 years. Now, with this global burden of disease, with this most common cancer, that's a huge number surviving. I mean, that is the importance of early detection. Next slide, please.
Yep.
So if we talk about the risk factors, why this cancer develops. So some of the risk factors we know about and some are still unknown. So the factors which we know about are sometimes modifiable and sometimes non-modifiable. And if we talk about the non-modifiable risk factors, which means that we can't do much about the to make the changes in those risk factors to decrease the incidence. However, they can be present in our family history. That means if somebody in the family has a history of breast cancer or the related cancers like ovary, he or she may be predisposed to a little higher risk than the normal for developing this cancer. So that is how the genetic risks underlying. If there is a personal history of breast cancer a couple of years back in the same individual, his risk of developing the breast cancer again in opposite breast or the same breast couple of years down the line becomes higher than the normal population. And there are certain types of breast cancer which are interlinked or the genetically inherited. It's something related to the menstrual history also. The early menarche or the late menopause, the more the body is exposed to the estrogens, that is how it poses a risk of development of breast cancers. And the racial differences, the ethnicity, African population to be more precise, they are more vulnerable to develop this cancer. Now, having said that, there are certain modifiable risk factors also, where we have the control over lifestyle changes. If we control them, if we modify them, we can decrease certainly the this disease to be happening in our body. And these risk factors are reproductive system, reproductive history. So, I mean, multiple pregnancies expose our system to higher level of progesterones. So that is how they say that actually multiple reproductive histories protect you from the breast cancers. However, I mean, it predisposes again to the gynecological cancers. That is how the way balancing happens. And if we talk about oral contraceptives, if somebody is using oral contraceptive for a longer period of time, they can also predispose to a 2 times more higher risk in females of for developing this cancer. Now, patients of near about the perimenopausal age, if they are exposed to hormone replacement therapy because of the postmenopausal changes and all, then they are at risk of developing this breast cancer. If somebody is in a habit of consuming alcohol on a regular basis, that is also predisposing. And obese patients or the overweight patients who are turning into postmenopausal are also at high risk of developing this cancer. Earlier, we thought that a moderate amount of alcohol intake is actually protective on body in terms of the cardiac conditions. But now WHO guidelines have been released, which clearly mention that zero tolerance for alcohol. Actually, alcohol is a bigger carcinogenic. Next slide, please. Again, I already discussed this slide that there are certain non-modifiable risk factors, that age is a predisposition. The postmenopausal patients are actually prone for developing these cancers. And we know that, I mean, females are more common to develop this cancer as compared to male. Only 1% of the male population develops this kind of cancer. Next slide, please.
Can you see?
It's not moved. Yeah, it has moved. Yeah.
Okay.
And like I already mentioned, if somebody has a family history, now what does that family history mean? That women who have close relatives with breast cancer, that is first degree relative, means the parents and the mother, sister, daughter, it doubles the risk. And patients or the females who have a second degree relatives, that is the maternal aunt, paternal aunt, or any side of hers having the second degree relative involved with that kind of cancer, also has increased risk. So nearly 80% of women with breast cancer have no family history. Sometimes it's the index case. So how does the genetic risk predisposes? So there is a change in that DNA or the genetic level, which predisposes these patients to abnormal multiplication of the breast cells. So that is how this cancer develops. Next slide, please. So again, if there is a personal history of previous breast cancer a couple of years back in some female, so she has a 3 to 4 fold increased risk of the second breast cancer. And there are certain breast diseases which are not essentially cancer, but they predispose to the development of cancer in subsequent period of time. And this is atypical hyperplasia and lobular carcinoma in situ. And this lobular carcinoma in situ patients are actually predisposed to bilateral breast cancers. Next slide, please. Again, a menstrual history. If there is early menstruation before the age of 12 and late menopause, that is after 50, it increases the risk. The Caucasian women have the highest risk of developing breast cancer. African American, Asian, Hispanic, and Native American women have lowest risk actually. African American women often are diagnosed at more advanced stage. That is what we are seeing in our practice also. Next slide, please. So again, reproductive history, having no children increases the risk slightly, and that is mentioned that multiple pregnancies because the progesterone level is a protective one. It protects, it gives us a kind of protection against the breast cancer. And similarly, having your first child after age 30 slightly increases the risk. OCP use increases the risk of breast cancer, and women who actually stopped OCPs more than 10 years ago do not seem to have any increased risk. Next slide, please. Again, I have highlighted this fact that some people use hormone replacement therapy for the treatment of postmenopausal symptoms. So they generally have slightly increased risk of breast cancer if they use this kind of therapy for 5 years or more. And if they stop, risk returns to normal after 5 years of stopping. Again, alcohol use, this is the last data that one drink per day increases risk slightly, but now WHO guidelines have told us the zero tolerance. Next slide, please. So again, if we want to protect ourselves from developing this cancer, the modifiable risks which can be catered very well are the physical activity. So WHO states that at least 30 minutes of brisk walk or a good physical activity 5 times a week actually decreases your risk of breast cancer. So next slide, please. So, like we were discussing, what is the importance of early detection of breast cancer? Why should it be detected early? Because as you can see the screen, that early detection can give you that good benefit of 5 year survival. If somebody is detected at stage zero, zero means that is in situ carcinoma. So then the survival rate at 5 years is approximately as close to 100%. And if stage one, it is as good as 98%. And if you go on to stage four, you can see that the 5 year survival rate decreases to 16% in the stage four setting. That is why the early detection is very important. Next slide. And how can we detect it early? So there are three ways. So in our country, there are good breast screening programs, though they are voluntarily, they are not run by the government itself, but good institutes, they propagate these early detection methods. And most of our doctors and nurses are trained for that detection methods. And these three detection methods are basically the breast self-examination, which every female should do on her own to detect it early. There is something called as a clinical breast examination, which is done by the doctors, say once in 6 months or once in a year. And there is something called as a screening mammography. Next slide, please. Yeah, so American Cancer Society also recommends to do a mammogram yearly for a women over 50 years of age. In India, our national guidelines recommend it actually once in 2 years to screen any female above 40 years of age to detect this cancer. And clinical breast examination, I told you that it is performed by a doctor. It is to be done say every 3 years for women 20 to 39 years of age and yearly for women over 40 years of age. And breast self-examination is something which is very, very important, and it can be done monthly by a female. I'll tell you how to do it. Next slide, please. So mammography, what is mammography? Basically, it's the X-ray of the breast to detect the breast cancer, and it can detect a breast lump before even it can be felt. So you can feel the breast cancer as close as if it is, say, 1 centimeter in size. But this mammography can detect it as early as, say, 5 mm or less, or maybe once it is in the form of non-mass like enhancement or a calcification kind of thing. And the studies demonstrate that mammograms reduce the risk of dying from breast cancer. Next slide, please. So, what is breast self-examination? When should we do it? So, the patients who still menstruate, that is the younger population in the reproductive age group. So, the best time is 2 to 3 days after your periods end, because during the periods there is the congestion in the breast or the breast engorgement with the blood is there. So that is why, I mean, it's very difficult for a small lesion to be picked up by breast self-examination. So patients, persons or females who still menstruate, the best time is 2 to 3 days after your period ends. And if the patient is a postmenopausal lady, you can pick the same day every month and do your breast self-examination, see the changes, correlate it with the previous findings, and you can have an understanding of it. Now, breast self-examination, how you can do is with the pads of your fingers, you have to touch every part of your breast in form of quadrants and feel gently for the lumps or changes under the skin. It can be very well done while taking the shower. And after you take the shower, stand in front of the mirror and just do it. Next slide. Okay, and you should include the arms at the sides, and arms should be put at the side, and it should be clasped behind your head. You should look for any unusual discharge from the nipple, any dimpling in the skin of breast, any changes in the skin texture, any changes in the shape or asymmetry of the both of the breasts, and look for the nipple discharge. Next slide. You can also do breast self-examination while lying down on your bed. Lie flat on your back and feel every quadrant of it, and feel if there is any lump or swelling or any abnormality felt. Next slide. Yeah. So, what are the abnormal breast changes which you can understand and notify it to your doctor? If you feel any lump, if there is any discharge from your nipple, if there is change in any breast size and shape of both of the breasts, or changes in the skin texture. Next slide. Yeah. So, there are certain myths and facts which we should understand before understanding this deadly disease. Next slide, please. So, a common myth is finding a lump in your breast means that you definitely have a breast cancer. However, it is not true. I mean, the truth is 8 out of 10 lumps are benign. That means they are not cancerous. So, do not let the appearance of lump frighten you to the point that you are afraid to see a doctor. So, every lump should be examined by a doctor, but that does not mean that you are having cancer. Next slide. Yeah, another common myth is only women with a family history of cancer get the breast cancer. That is not, however, true. Having family history increases your risk, but almost 80 to 90% of women who get the breast cancer have no family history at all. Next slide, please. So, one important fact is men also are prone to have breast cancer. This is, I think, 1% of all breast cancer, but however, it is the truth. So, any male person who is actually feeling a swelling or a lump on the chest area or the breast area, please get examined yourself with a doctor. So, males can also get a breast cancer. Now, another common myth is only women in their 40s and 50s get the breast cancer. However, I mean, it is recommended to perform a baseline mammogram at age 40 and make sure that you do regular breast self-examination. You are never too young or never too old for examination and having this deadly disease. Next slide. So, many people think that use of antiperspirants or deodorants can cause breast cancer. However, an urban legend traveling over the internet claims that the leading cause of breast cancer is clogged pores. in the underarm area. This is simply not true. So if it were, why do more breast cancer occur in the left breast? So, I mean, that is a thought-provoking process. Next slide, please. Mammograms cause the breast cancer or spread? No, it's not true. So mammogram actually is the simple X-ray of the breast. If a cancerous lesion is picked up early, it can improve one's chances of curability. However, we need to understand that mammogram may miss about 10 to 20% of the cancer. Next slide. So that is why the higher modality to detect breast cancers are also important, and we'll be talking briefly about them also. And if you are at high risk of breast cancer, there is very little thing you can do about it. That's also not true. So nowadays, there are multiple options for the treatment available. At Max, we will also discuss with you what kind of advanced treatments we are offering to the patients and how they are increasing our success rate of survivals. Next slide, please. Yeah, this is very important. So, as we know that the cancers are lifestyle diseases, so you have to be very careful about your diet, your lifestyle, your physical activity. A high-fat diet is not good for you actually, but there is no direct correlation between breast cancer and the high-fat diet. Next slide. So, okay, and one common talk about is an injury to the breast can cause a breast cancer. So, an injury to the breast may result in the detection of breast cancer, but there is no direct correlation of the injury to the causation of this cancer. Next slide. Okay, only large-breasted women can get breast cancer. Is it true? So the truth actually is, by virtue of being a woman, each one of us has some risk, regardless of race, breast size, or socioeconomic status. So small-breasted women are not, are not at lower risk of developing breast cancer. Actually, next slide. Okay. So this is a very disheartening myth which is there in the society that if you get this cancer, you will probably die. However, there is a lot of advancement in treatment of this breast cancer as well as the diagnostic part. So that the longevity, as we discussed, that if we are detected early, it is 5-year survival is as close to 95 to 100%. Next slide. So I think we will skip this slide. We have already discussed, and next slide I'll discuss something about the treatment. Okay, so what are the treatment modalities available to beat this cancer? So it depends upon actually stage. If we are and actually the type of breast cancer. So there are three important type of breast cancer: the hormone positive breast cancer, the triple negative breast cancer, and the HER2 positive breast cancer. And if it is a hormone positive breast cancer, it's the most favorable variety. Why most favorable? Because the survival is better. There are hormone therapies that is in the form of tablets which can be offered to the patient. Surgery is almost a curative attempt here. So that is why this type of cancer is the favorable biology. Now, if somebody has a triple negative breast cancer, nowadays the genetic based treatments or immunotherapies are available, and the complete response rate with this kind of targeted and immunotherapy is to the tune of 70%. What does that mean? That out of 100, almost 70 people will have a complete disappearance of tumor in the early stages if the immunotherapy or targeted therapy is used in such type of cancers. So these are the triple negative or the HER2 positive cancers. So that is how the treatment paradigm is changing and is revolutionizing the treatment of this cancer. And we in India are equipped with these kind of new advancements and new treatment paradigms, and we are using it regularly for our people here. So in terms of radiation therapy, there are good machines, latest advancements in the form of proton, in the form of IMRT, IGRT techniques, which are treating the people to the precise extent, and the vital organs are spared with the, toxic dose of radiation. And something about precision oncology, which is our portfolio at Max. Say one size does not fit all, so that is why one treatment may not give the similar results to all kind of patients. So that is how the precision oncology comes into play. So precision oncology is basically delivering the personalized care of cancer treatment to each individual. So what does precision oncology do? Is it actually studies the molecular alteration in the tumors to detect the targetable defective genes in the patient's tumor, so that a particular kind of targeted therapy or a drug or immunotherapy can be offered for the cure of this cancer. And we have the ctDNA facility to detect the cancer or the minimal residual disease. We have next generation sequencing or the molecular profiling for the cancers which is available. So that is how we are having that expertise in precision oncology also. Thank you so much for the patient listening, and I'll rest my talk here. Thank you. Any questions are welcome.
Wow, thank you so much, Dr. Shefali. That was quite insightful and quite eye-opening. I'm going to open the floor to us. If you have a question, kindly just press the button that raises your hand. When you raise your hand, you'll be unmuted, and then we can ask the questions, or you can post them in the chat and I'll read them out loud. I can see there's a hand raised. Pancras, you have a question?
Yeah, exactly. So yeah, I'm asking from a man's perspective. You've managed to talk about how we can do self-examination as women. I think even the pictures, I think the diagrams are actually showing how a woman should do it, or probably we're talking from a woman's perspective. Now, this is asking on behalf of men. Is the procedure the same for men as well, considering most of our chests are usually super flat? And then are there specific things that are different from women that we need to check when we are self-examining as a man? Or what are your thoughts around this?
Yeah, I think a good question. So, since the male patients do not have that fat tissue or the subcutaneous tissue around their chest wall or breast area, so that is why essentially the examination part is similar in both male and females. However, it is easily and better detected in a male because any lump or swelling will be obvious on the chest wall if it is there. So you can easily palpate it around the nipple area. And if you feel any swelling or any enlargement of the area or any hardness there or any discharge, obviously you can always notify it to your doctor. So the most common symptom in a male is a lump or a swelling. They hardly have any discharge because there are very less mammary glands or no subcutaneous or adipose tissue lying there. Yeah.
Thank you.
Thank you for that, Doc. I can see Sheila has raised her hand too. Sheila, go ahead and ask your question.
Hi, good evening, everyone. Thank you for this talk. I just wanted to ask a question about an unrelated cancer, but I think it's less talked about, especially for early detection. And I wanted to know if there are any like markers or any indicators somebody can look at for cervical cancer. I'm asking because I know my family is predisposed, and is there anything I should be looking at? I'm in my 30s.
Yeah, wonderful. I mean, I am very happy that you asked this because cervix cancer is also one of the most common cancers in Indian patients also. And WHO has recently launched a program to eradicate this deadly disease by another couple of years. So actually, there are two important aspects about this cancer. Number one, nowadays, there is a vaccine which is available to prevent this type of cancer, that is cervix cancer. And these vaccines are effective to the tune of, say, almost 70 to 75% to prevent this. Because we know that this cancer is caused by HPV virus, that is human papilloma virus. So that is why the girls who are basically not yet sexually active or not yet married, actually they should be given this cervical vaccine. And we can use 2 or 3 doses depending upon the type of vaccine available. And that can give you almost 70 to 75% of protection against this cancer. Now, however, if somebody has not got this vaccine and is predisposed, like you told that your family has that history, So the earliest symptom of this cancer is the postcoital bleeding. So as soon as you get this symptom and you have that family history, please go to your doctor, get yourself examined, because if it is again picked up at very early stage, it's almost 70 to 75% curable. So there are good modalities of treatment available. In stage 1, you can go for surgery always. In stage 2, 3, you can go for concurrent chemoradiation that gives you curability. And even in stage 4, to some extent, now the newer drugs like immunotherapy and targeted therapy are available for treatment. However, the results are not that up to the mark as the early stages. So early detection is the way to success. Yeah.
Wow, thank you for that, Doc. Doc, I have a question. We had collected some questions before, and someone wanted to know if the diagnosis of breast cancer is made during pregnancy. How should one progress? Maybe it has been discovered in the early trimester, in the first trimester, or the second or the third. What choices are there? What options are there for the mother? And are there options that can actually allow the mother to keep the pregnancy to term and deliver the baby and still get treatment without putting both lives at danger?
Yeah, great question. So, say a couple of patients do get this problem while having the pregnancy, and it's very difficult to diagnose there because of the pregnancy induced changes also, and because of the limitation that we can't do certain tests to diagnose it. Neither we can do mammogram at that time, neither we can expose the patient to CT scan because of the pregnancy which she's carrying. So that the treatment and the diagnosis depends upon the stage where we are expecting this. So if say somebody is expecting or having that suspicious lump in the breast in the first trimester, and before the 20 weeks of gestation actually, so then we advise the patient, if it is detected and diagnosed, that to abort that pregnancy. If it is not the precious pregnancy, or say the child which he or she is bearing after, say, so many treatments and so many years of married life, and it is essentially important to keep that, because there are risks of fetal malformation with the treatment. So in first trimester, we generally suggest the patient to do so. Say if the breast lump or cancer is detected in the second trimester, we actually try to give some kind of chemotherapies which are actually not teratogenic or carcinogenic, and we try that the fetal age should be brought as close as to lung maturity, that is 32 to 36 weeks, by offering the medical treatment, so that once that maturity is reached, we can do the early cesarean and deliver the baby safely, and then can fully diagnose and treat the breast cancer. And if it is a third trimester, I think that is not major problem, because by that time already the fetal organs have formed, and as soon as we get the lung maturity for fetus, we can always get an early cesarean and raise the baby in PICU, and so that the baby stabilizes, and simultaneously we can treat the female. So that is how we have managed couple of our breast cancer patients in pregnancy.
Okay. Thank you so much, Doc. Another question was for patients who are getting recurrent breast cancer, say they had, you said if you have a risk, if you had cancer before, you have threefold or fourfold risk of getting the cancer.
Yeah.
The recurrence, is it usually, does it come back in a different like morphology or a different type? Maybe if you had HER2 positive, now you can get a triple negative, and is the second one harder to treat than the first one? Or is the success rate, if caught early, still the same, the success rate of treatment?
Yeah, great question again. And I mean, it's not a simple yes or no for this question. So now we need to understand that if it is a triple negative or a HER2 positive type of breast cancer, it certainly has a higher chance of recurrence as compared to the hormone positive. And these kind of cancers like triple negative have an underlying genetic history sometimes. So all patients of triple negative breast cancer, we test for BRCA gene mutation, BRCA1 and BRCA2. 2. So almost 10 to 15% would bear this kind of genetic mutation. And nowadays, the directed targeted treatments for this gene mutations are available. And in India, we are commonly using these treatments in adjuvant setting, that is post-surgery also, and in metastatic setting also. They are FDA approved treatments now. Now, if there is no genetic predisposition per se, and there is a recurrence of breast cancer, again, it depends upon at what time point are they recurring. Say, if we treated the breast cancer more than 6 months or a year back, and now it has recurred after a year or more, duration, then we would like to rebiopsy it always, because the characteristic of the tumor may change. So a triple negative earlier tumor may become a hormone positive, low hormone positive, or a HER2 positive if it is a different type of tumor origin. Now, if it is the recurrence of the same malignancy, it may bear the same hormone receptor. So we would always like to biopsy it and then guide our treatment based on that. Now, if it was a left breast cancer earlier and it is occurring in the right side right now, it may be a different type of biology. So that is how the importance of the time duration after the treatment and the repeat biopsy matters. And these tumors in at the recurrence or at the later ages also are curable if they are detected again at the early stages, or there is a locoregional recurrence. If there is a metastatic disease, of course, the prognosis would change.
Okay. Okay. Thank you very much. Sagnik, you had also raised your hand for a question.
Yeah. So I do also have one question related to some of the dietary restrictions. So, ma'am, is there any scientific evidence that suggests that there is a role of ketogenic diet in preventing or managing breast cancer? And how do this like low carbohydrate diet can be recommended for breast cancer patients?
These diets do not have a direct correlation. However, we saw that obesity or weight is an important risk factor for development of this cancer. So that is why all the diets which lead to increased weight gain or obesity, like red meat particularly, or a high fat diet, or a high sugar containing diet, or a high carb diet, these actually increase your body mass index and prone you for obesity. That is an indirect factor which leads to the predisposition to breast cancer. However, none of the diets has till date proven to be a curative diet for breast cancer. But there are certain studies which say that breast cancer is an inflammatory condition in the body. So if certain diets which decrease the inflammation into your body, and particularly there are now ample studies available in the literature that vegetarian diet actually decreases the chances of any type of cancer, particularly the colon cancer. And why it happens is because once you have a non-vegetarian diet, which is high in the fat content, actually the telomere capping, it goes away. Telomere is a kind of thing which is there in our genes. And telomere cap prevents anybody from aging, right? So if the telomere cap get destroyed, the aging becomes faster. So actually, any patient who is phenotypically or morphologically 18 to 20 years of age may be actually genetically 60 years of age if there is an inflammatory condition in the body. And that is why these persons are predisposed to certain other lifestyle diseases. You may be hearing now that 18 years, 20 years of old patients are getting heart attacks or cardiac condition. Why this is happening? They are leading a good lifestyle. They are physically active also. But when their genes were studied, this is a published literature, and this is published from a good reputed institute in India, four studies, and from the West also, if you see. So if you study their genes, there is every reason that their telomere caps are destroyed. They are genetically 60, however, their actual age is 18. The body age is 18 or 20. So that is how it is affecting the body. And now the people are doing more and more studies, and they are switching over to the, say, green vegetables or the colorful vegetable diet as compared to the non-vegetarian diet.
Thank you, ma'am. Thank you for your response.
Wow, thank you.
I have unmuted the participants who want to ask the questions. They can go on, and please unmute your mic.
I think Fiona has hung, so I think we'll allow Dennis to ask the question. Dennis, you had a question.
Yes, I do. Can you hear me?
Yes, we can hear you
Yeah, I can
now.
hear you very well. Yes.
So my question is, at what point does the breast cancer mutate to other parts of the body? Because at one point in my research, I did see that there are instances where the breast cancer can move to the brain. Then from my research, I've also seen instances where the breast cancer moves to other body parts, causing things like bones to be soft. I'm not sure whether I'm saying everything correctly. So are there instances where the breast cancer mutates, and at what point?
Yeah, great question. So, like we discussed different stages of breast cancer. So, what does that mean? So, if it is a stage 0, that means it's a carcinoma in situ. In situ carcinoma means that breast cancer has started developing in the breast cells. However, it has not crossed the membrane or the outer lining of the breast cells. So, there the potential is that it has not yet spread to any of the lymph nodes or the organs in the body. And if removed completely, I think it's 100% curable. That is what the data says. Now, if the breast cancer becomes stage 1 or stage 2, now what does that mean? That breast cancer cells have traveled from the organ of origin to the nearest draining nodal area, that is the axilla. So that means it has come out of confines of breast, but it is still localized to the draining area only. So there are still almost 80 to 90% chances that it is still curable because it has never not traveled through the blood or hematogenous route to the other organs. Now, if we come to stage 3, that is extensive lymph nodal burden in the axilla, or if it has traveled from axilla, the microscopic cells have traveled, it's a long-standing tumor, then there is a potential for the breast cancer cells to spread all over the body, and the nearest organ is lung. It can spread to liver, it can spread to bones, depending upon what type of breast cancer it is. So that is how the spread according to the stage is there. Now, mutation in a breast cancer is not exactly related to the metastasis. These are two different terms. Mutation is in the genes. All breast mutations do not predispose actually to the stage 4 cancer. They can be also detected early in stage 1 or 2. So it is actually the stage which decides the prognosis.
I think he's dropped out, but can you hear me now?
Yeah,
Yeah,
we can
I can
hear
hear
you.
you.
Okay, okay. I can see Eric has a question. Eric, can you go ahead and ask your question? Eric?
Good evening, guys. Can I be heard?
Yeah, we
Yes,
can
we can
hear
hear
you.
you.
Yes, please.
My question goes to the facilitator. This is Pancras. I'd love to ask because medical tourism in Kenya is a unique kind of setup where we are trying to reintroduce it probably to people who have not used to it. My question will be, what kind of assurance can you give to patients who may want to go to India for treatment? And what make your FitPath a unique kind of approach in terms of other medical tourism? Or I know there are competitors in the market. So what will you mention as a unique kind of approach that your FitPath comes into the industry of medical tourism?
Thank you very much, Eric. I hope I got your name right, Eric. So to answer your question, in terms of medical tourism, your FitPath in this case, what exactly do we offer that is unique compared to, I would say, competition or any other person who's actually doing the same kind of, providing the same kind of support to patients? Number one is, to me, I think the one offering we give is the patient experience. So everybody else can be able to treat a patient. Everybody else can be able to provide drugs or do surgery to a certain extent, either quality or any other way. But to us as the facilitators, one thing that is extremely close to our hearts is the patient experience all through the journey, from the time where we reach out to you to offer you the kind of help and value proposition that we do have, to the time that we reach out to engage with our doctors at Mark Circuit, to the time after you've gotten your treatment in India, and to the point at which now you're traveling back, we make sure that you're happy. we make sure that the doctor who's treating you is walking you through that treatment journey within the hospital, with an understanding of what the treatment plan is. You don't just go there for surgery, you don't just go there for treatment, but we're able to make sure we take you to a place where you will be comfortable and you don't feel like you're in a foreign land. What else do? We try to ease the burden. We're not here for business. We're here with compassion. We're here to tell you that we do understand that you're already overburdened by the financial situations, and we throw in something in support of the same. We tell you, for example, at YourFitPath, we don't just let you travel for treatment, but we also, like, for example, support you with free air ticket for some specified number of type of patients that are seeking treatment in India. Not for all of them, but for most. We also, like I mentioned earlier, we don't just dump you in India, in a foreign land where you have no idea where to get to start. So we have a team that's always waiting for that flight to land, so that now they can pick it up from there, show you, take you to the hospital, ensure that where you're getting your rest and accommodation within India, you're fully secure, and you're also at a place where you can easily be able to access the services of the hospital during the observation period of time. That does not end there. When we are sourcing for the doctors and the specialists who are going to treat you, we don't just float a name simply because we know they can do it. No, we do our research and we give you the numbers so that you can be able to take a decision from an informed position where you say, for example, Dr. Shefali, this is how her numbers are looking like. This is what her success rate is looking like. So we don't just tell you to go there. We are telling you to trust this particular doctor to be able to give you a much better result if that's what you're looking for. So that is what we do. We are not so much interested in anything else except your fitness as an outcome. So that is what is extremely unique to us. Now, before I leave, what's even better is the fact that before you leave, or even after you come back, we give you free consultation. So access to the doctors is not a problem. Talking to them is not a hindrance. Like, there's nothing that's going to stop you from talking to them, engaging them, just so you get all the confidence you need to be able to move forward. I do not know if I've been able to answer your question conclusively. If not, please let me know.
Yeah, may I add something here?
Yeah, please. Yes, please.
Yeah,
Yes,
so
please.
one thing, I mean, great question you asked, and this is the question in everybody's mind if somebody is traveling to a far land for a treatment for the near and dear ones. So one thing, what we make sure at Max is what is our policy is the transparency of the treatment. I think from the start of your journey till you are with us, and I think it's a long time. So medical oncology is not a short time treatment, and there is a connect which is emotional. There is a connect which is personal. There is a connect which is actually there to guide you through that treatment. And apart for that whole transparency of the treatment, what does that mean is starting from the day one, you will be able to get your whole plan of the treatment upfront, that how should we start and where your journey is going through, and how are we taking you to your journey. And if you are planning to come to India for treatment with us, then I think we are okay that if you want to have a word with us before you plan and to understand, okay, what will be your tentative plan to guide you in a better manner. So I think, and that makes Max also stand apart in this treatment. Yeah.
Mm. Wow, thank you. So we'll take two more. I can see Sarah. Sarada, are you still here to ask your question? Maybe Aurelia Vera, you can ask your
Yes.
question.
Hello.
Yes, Sarada, please. Yes, Sarada, we can hear you.
Yes, ma'am, thank you for a wonderful presentation. And I have actually two questions. The first question is, as we know that cancer is like a old age disease. So basically, BRCA1 and BRCA2, both the genes are responsible. So in genetically, can we are in a position to make a personalized medicine for different patients and their conditions, like stage 1, stage 2, like that? And my second question is, what are the nanoparticles roles? Like, is there any particular nanoparticle found which can be a very good medicinal impact in this breast cancer and all that much only?
Yeah, thank you for asking a great question. So to answer your first question first, cancer is not the disease of elderlies nowadays. Like I spoke about that, the premenopausal young ladies also get this kind of cancer, and the youngest patient which I have treated in my last 20 years of career is 17 years old colon cancer. So it's not a disease of elderly, first of all. Number second, the youngest breast cancer what we have seen in our clinic is 22 years of age. So again, we know that in these patients, the genetic predisposition is playing an important role, and the BRCA1, BRCA2 genes are important to mention a few. And the treatment modalities against these genes are nowadays available. So if somebody is detected at stage 2 or 3 in triple negative or a hormone positive and has underlying BRCA mutation, so we are offering 1 year of this anti-BRCA therapy, which is called as PARP inhibitor, after you finish your surgery and your chemotherapy and radiation part. So the lady will get 1 year of that PARP inhibitor treatment to target these genes. And if unfortunately she's diagnosed at advanced stage, that is stage 4, so again this tablet or a PARP inhibitor, what we call, comes into play in her treatment paradigm. So that is how the treatments are available targeting these genes. Now, to answer your second question about the nanoparticle, of course, the nanoparticle technology is available with us in India, and we are using certain nanoparticle based chemotherapies to treat the cancers, like nanoparticle albumin bind paclitaxel. We have liposomal irinotecan. We have other drugs which are developed by this technology and are routinely available in India for treatment of these cancers.
Drugs like doxorubicin and
Yeah,
like all the drugs are also available, but
yeah,
always those coming with a lot of side effects. So, is there
absolutely.
any nanoparticle that doesn't have much of side effects and all?
See, after all, nanoparticle is basically a technology to what happens is, see, these nanoparticles bind to the drug, and they cross the lipid formulation membrane, the cell membrane, very easily, and deliver the drug to the target at a particular site. So the toxicity is less as compared to the conventional molecules, but of course they are not free of toxicity. So having said that, if you have heard of nanoalbumin bind paclitaxel, which is nab-paclitaxel we call, so it does not require steroids in a huge amount as the conventional paclitaxel would require in a treatment. But however, it is associated with certain kind of neurotoxicity. So of course they have lesser kind of side effects. They require less kind of steroids, but they do are associated with certain side effects. None of them is free of side effects at all. Yeah,
Okay, ma'am. Thank you.
yeah. Thank you.
Thank you. Thank you very much, Doc.
Sorry for the interruption. She messaged me
It's okay.
actually.
Oh,
I'll ask from her behalf the question. So she is telling that what lifestyle changes or practices can support the treatment and recovery of cancer and potentially improve the overall health outcomes.
Wonderful. So lifestyle changes to prevent the cancer and to treat, and during the treatment of cancer are very important. Now, to prevent, we already discussed that you should have a good physical activity, you should have a healthy diet, you should have more of the vegetarian diet, so less of the sugars. These kind of lifestyle changes actually help you for the prevention. Now, if somebody unfortunately gets this disease, now, during treatment, there are certain changes which your body is going through. After all, this treatment is a stress to your body also. So now, during treatments, we generally advise our patients as a general bottom line that they should have at least cooked food. Home cooked food is always better in terms of hygiene and the practices. So say the cooked vegetables and salads are very important. Do not consume them raw, because already your tummy is at stress with the use of chemotherapy. So we make sure that no outside food disturbs you. So we don't allow the outside food that you should take during your treatment. Now, as far as the fruits are concerned, if somebody is diabetic, so of course the diabetic restrictions should follow. But otherwise, as far as the chemotherapy is concerned, there are no dietary restrictions in terms of the fruits or other foods. Of course, during chemotherapy, once your tummy is at stress, sometimes people feel like bloating, sometimes the constipation and diarrhea issues are there. So then we suggest on case by case basis certain modifications, that if somebody has loose stools, please avoid the milk based products, please avoid the juices. And if somebody is constipating, so we tend to err on the side of, say, sometimes the high fiber diet or the high intake of liquids. If somebody has bloating, we tell them to have something called as a brat diet. What is brat? Is banana, curd, and the apple based diet. So this is easily digestible. The fermented foods are so, because on chemotherapy sometimes the smell and taste changes may occur. So that is why the kind of foods like fermented food or curd based food, which are more palatable, help you to tide over that time. So actually these kind of diet modifications we suggest to our patients during on treatment.
Okay, so thank you so much, Doc. Unless there are any other questions, I think I'll request that we still have the WhatsApp group open. If you have questions, feel free to post them there, and we'll direct them to Dr. Shefali. As well, if you know anyone who might benefit from having a one-on-one consultation with her, please let us know. Reach out to Pancras, reach out to Sagnik, reach out to myself in the group, and we'll be able to organize for a call with Doc. And thank you so much, everyone, for attending the webinar. It's been a great pleasure. Thank you so much, Dr. Shefali. And we hope we can have you more for another session, maybe on cervical cancer, one of the cancers you specialize in. Thank you very much, Pancras. I can see Aurelia is raising her hand. Oh, she's dropped her hand. Okay. Thank you very much, Sagnik, for organizing this. Thank you, YourFitPath. Thank you, Pancras, and your team.